Anil sir, shall we begin?
Yes, yes, Rahul. Sorry.
So, hello everyone, good evening. I'm Rahul. I am the co-founder of Poornima University and director at Poornima Group Jaipur. We are a 20-year-old organization, and Poornima University started in 2012. We started public health courses with Jodhpur School of Public Health 2 years before, and this is our, I guess, 16th or 17th webinar that we are doing. Uh, and it's an honor for us to host the webinars in this era of COVID-19, where everyone is virtually connected. And just to give you an insight that it started with Anil sir when he came to Jaipur, and when we met, we decided to begin with public health courses. And currently we have masters and PhD programs in Poornima University, and also bachelor's program. And JSPH has been helping us a lot in organizing the academics as well as these webinars, which are in interest of the students and the faculty members at Poornima. So I thank you all for giving us the opportunity to host these programs, and I welcome you all in this webinar. And I am a big fan of all the public health practitioners, and it's been an honor to listen to all of you in past 1 year, and a lot of learnings and a lot of takeaways which cannot be expressed in 2 minutes. So I would now request Anil sir to take this over and take the webinar forward. Thank you so much.
Thank you, Rahul. It's been a great journey with you for last 1 year, and I think we are learning a lot together. And we're very thankful to you for supporting the School of Public Health and Public Health overall. Um, I, Good evening, good morning, good afternoon, everybody. I will give brief introductions about everybody on this panel, and also about these briefly about School of Public Health and about the webinar, and then we'll just jump into the distinguished speakers, lectures, and and I think it'd be a very, very interesting hour and a half today. The Jodhpur School of Public Health is 12 years old, and it was established in 2008 in Jodhpur, and now we have a second branch in Jaipur. As Rahul said, we've been running these webinars for last more than a year, almost a year since the pandemic began, and this is the 16th or 17th webinar. Today's webinar focusing on pandemics and public health with focus on lessons learned. This, I would say, Dr. Samia Swaminathan coined the topic this time. Last year we had Dr. Srinath Reddy and Mr. Rao coining AIDS to COVID, the rocky road of public health. So going forward, I would like to start the introductions. Rahul is an architect by training. It's a family-run foundation and institute. And Poornima has many disciplines, including engineering, business, health sciences, and now we have School of Public Health. Recently, they went through the UGC inspections, and they did very well, I guess. And his father runs the Medipulse Hospital in Jodhpur with his brother, and they're setting up another institute very soon. Like to start my introductions with Dr. Samia Swaminathan. She's the Chief Scientific Officer at the World Health Organization headquarters in Geneva. Prior to that, she was the Director General of Indian Council of Medical Research in New Delhi, India, and Secretary Health Research. She has done amazing work in tuberculosis and pediatrics. She's been trained at AFMC Pune, the Armed Forces Medical College, also in Los Angeles. And uh, for me, it's very important. She was also my boss in Chennai when I went for 3 months to University of Washington. I had the I had gone to India to establish the Indian entity through University of Washington, and she was my boss, and it was really fun working with her and knowing her more closely. So we're very honored, Sonia, to have you, and everybody's looking forward. And we have overwhelming registrations today. Also, I got a message from somewhere that she's the pride of India. So congratulations. So it has come from an audience. Dr. Srinath Reddy, we all know him. He has been on lots of webinars. He's a cardiologist, a very popular cardiologist. He is the president of Public Health Foundation of India. And we're honored to have Dr. Reddy. Professor Prasada Rao, former Health Secretary of India, Special Envoy to Ban Ki-moon, UN Secretary General for AIDS in Asia. And he does wonderful work. He teaches at Jodhpur School of Public Health. And he has changed the face of HIV/AIDS in India. And we would like to hear from him today. How will he relate the lessons learned from HIV/AIDS to the current pandemic, which we all are going through? Dr. Arvind Mathur was the Dean of Medical School in Jodhpur, Dr. Hassan Medical College. He's the internist by training, and he's done wonderful work on geriatrics and HIV. And he would be talking about the geriatric population, how they have dealt with the COVID and how they're dealing and how he's taking care of them. We will be looking forward to hearing from you, Dr. Mathur. Dr. Ratik Godrej, uh, sorry, something with my. Dr. Rati Godrej is an internist trained at University of California, Los Angeles. She used to practice at Mumbai American Consulate. She is on the board of Public Health Foundation of India, also on the India Health Center at Harvard T.H.N. School of Public Health in Mumbai. She has been a very, very big support to the Jodhpur School of Public Health for last more than a decade. She just was attending another webinar and she has just come on time. And we look forward to hearing from you, Rati, about your experience, what you're seeing in Mumbai. Like some audience have sent messages to like to hear why Bombay is being semi-locked down, and these are some audience from outside India. So maybe you could answer that question if possible during your presentation. Dr. Pankaj Bharadwaj, dear friend, he's at All India Institute of Medical Sciences, additional professor. He does a lot of work on vaccine, and he has been a pillar in establishing the School of Public Health at AIIMS Jodhpur. Um, Jagdish Hirsch and Greg Fant would be moderating. Jagdish and I have worked for last 2 decades. We started to work together on the HIV pandemic when we had the Gates-funded project, and he runs a technology company called Mobilite in Delhi with branches in Boston, London, Singapore, and does a lot of work on health-related issues. Uh, Gregory Fant and we work together at HHS Health and Human Services in United States and Washington. He has also worked on organ transplantation. He has set up a Society of Epidemiology in Jodhpur, which probably will be sending you some information at some point. And currently, he's a field epidemiologist at the Veterans Administration in Washington. Plus, he's on faculty at Jodhpur School of Public Health. He travels to Jodhpur at least 2 or 3 times a year. This year, he has been missing and hasn't traveled. Bhavna Sati is the head of the department of Epidemiology at Indic-Chain Institute of Technology.
I think,
Did we lose Anil? I think we've lost Anil.
yeah. So I think carrying forward, I would request the moderators to please take over and proceed. And I think we're waiting for Soumya ma'am to begin her distinguished lecture. That's what the plan is.
Yes, so good evening. I think Soumya, I think you should take over and start, and we'll take over soon after. Why don't we
Okay.
go ahead, please?
All right. So first of all, thank you all so much. It's a pleasure to be with this very distinguished panel this evening, and greetings to the students and others in the audience. What I'd like to do is, I think from my perspective, maybe just go over some of the lessons that I think the world has learned or should learn from the experience of the past, 11, 12 months, or maybe a little more than 12 or 13 months. And maybe with a specific focus on India and what we should be doing to prepare ourselves really, and from what we've seen happen over the last year. Now, let me just say a word about epidemiology. I'm not going to show any slides because I think everybody is fully up to date, and there are so many websites now where you can look at the latest information. It's amazing, actually, the amount of public websites that have been put together by different agencies that make available the latest data literally on an hour-to-hour basis. So we know there are over 110 million cases. This is confirmed cases, and over 2.5 million deaths. Again, these are confirmed and notified deaths due to COVID-19. And why I say that is because it is clear that the true burden of the infection and perhaps of mortality as well is not captured in these numbers. And we know from countries and regions and cities that have done prevalence surveys, for example, India is a good example. The national prevalence surveys conducted by the ICMR tell us that 21% of adults are infected, are seropositive, and that in some cities, this goes up to 50-60%. In Nigeria, where they've reported, I think, only 50,000 cases and 1,800 deaths, it's a country of 200 million people. A recent sero survey in Lagos state showed again that 20% of adults were infected. So what's going on? And I think this question is being asked now. I see a lot of articles being written about the Enigma of India and of South Asia. It's linked with several things. The first one is demographics. I think the median age in India is about 27, 28. The median age in Africa and many countries is around 20. So you have in a country like Italy or Japan, 25-30% of the population above the age of 60, 65. In a country in sub-Saharan Africa, hardly 1 or 2% of the population would be above that. Therefore, clearly, COVID-19 has shown that it causes much more serious disease in older people. And so the demographics of these regions are protecting us. And to a large extent, I think we can explain why there's so much of mild and asymptomatic infection compared to Europe. Now, the second, then of course, there have been many theories that have been put forward for why such a low mortality rate, including genetics, innate immunity, immunity due to other viruses, exposure to other viruses, etc., different strains of the virus. All of this needs to be explored, and these hypotheses need to be backed up by data. And I think it will be very interesting, actually, to do some of the studies to really look at what's happening in the nasal mucosa in people who are living in environments which are, urban, dense environment. You're exposed to not only air pollution, you're also exposed to a lot of other upper respiratory infections. Is the interferon, beta interferon response in the respiratory mucosa different than it is in countries where you're living in a very, sterile sanitary environment? And it's a good question, but it needs data. There's also been theories put forward that the genetics of the Indian population may be protective. Again, just hypothesis. We need to look at data, and it's very complex because this is multifactorial, the outcomes of this. And so you need to do very complex statistical analysis, taking into consideration many, many factors that are playing a role before we can come to the conclusion. But also I think the importance I want to bring in here of CRVS, that is the civil registration systems, which record births and deaths, vital statistics, what is called vital statistics. In many countries where the system is good, you can rely entirely on the system of death reporting in the country, whereas where you have a real-time understanding of what people are dying of and where, and you can immediately measure excess mortality, etc. That's what happened in many countries which have that system. But again, for many developing countries, including in India, less than 20% of deaths are actually classified by a medical doctor with a cause of death. And while death reporting on the whole is increasing, and but even there's a gap. The cause of death reporting there's a huge gap. And that is why we, at any point, cannot know what is the real mortality due to this disease, or for that matter, excess mortality due to other diseases. And we'll have to wait for several years to find that out, through the surveys that are done. So this is a huge gap in our public health system, and it needs to be filled. When I was in the ICMR, we had thought of many ways of doing this, but I think this might be good for the panelists to give their opinion from their experience, but also for us to think about for the future. So I was talking about epidemiology and how this disease has really played out so differently, and sometimes it has surprised people the way it has behaved. So right now, we saw the first wave, the tremendous amount of strict measures people put, lockdowns, etc. It went down, particularly in Europe, where I've been observing this closely over the summer. People were really happy that everything had seemed to go back to normal, and people started going about and socializing like before. And then very soon we saw in September, October, the cases going up. And then soon after that, it was found that the variant that was spreading across Europe was something that had started in Spain during the holiday season in the summer. And then, of course, the description of the variants, etc., have caused a lot of anxiety now. So we've seen these waves coming and going. We've also seen that when public health measures are put in place, the transmission does go down. The moment you take your foot off the brake, it goes up again. Currently, we've seen several weeks of sustained lowering of global cases, incidents. At one point of time in January, early January, we were seeing almost 1 million cases, in fact, about 800,000, 850,000 cases every day. And the deaths had gone to like 16, 17,000 per day. Luckily, over the last few weeks, because again, many countries took strict measures, it's come down. But I see today, for the last couple of days, there's a plateauing globally. The downward trend seems to have stopped. It's plateaued, and we're looking at something like 500,000-600,000 cases a day with about 10,000 deaths per day. This is much higher than what we saw in the first wave, which happened in March, April of last year. So the virus has expanded its footprint. It's gone into practically every country in the world, and it's there, it's transmitting, so that the moment you relax a little bit, it goes up. It's also had an opportunity to mutate, as all RNA viruses do, and it's accumulating mutations, which many of them make no difference at all to the virus. Some of them help the virus to transmit more efficiently, and the others may actually be detrimental to the virus. That's a normal evolution of any virus. What we are interested in is if any of these combination of mutations is a variant of concern. And a variant of concern would be something that has an impact on transmission, making it more transmissible, has an impact on clinical severity, or has an impact on the susceptibility to antibodies, which are generated from prior infection or through vaccination. So these are the three measures that we would like to see. And it's not of much utility if people just report, we saw X mutation, X strain. So the genomic surveillance needs to be combined with clinical and epidemiological data to really make sense of it. And that's how we learned about the UK, the B117 strain. Very careful studies were done to show that it's about 1.5 times more transmissible, and perhaps also a little more severe because there were more deaths as well happening. It was also infecting more young people. Similarly, the B1351 mutation in South Africa clearly is much more concerning, because the E484K mutation is impacting on the ability of the antibodies to bind to the spike protein. So it's affecting vaccine efficacy. We still need to learn much more about the other variants that are circulating. And the fact is that the genomic public database, GISAID, allowed the world on the 10th of January last year to learn about this new virus, but also to keep track of the evolution of the virus since then. I think lesson number one is that our public health surveillance now needs to include genomic surveillance, and needs to be done in a way where it is looked at with the necessary metadata, which is a clinical and epidemiological, not enough to just do sequencing and put it up. The other thing is the sharing. The public sharing of this data, which happened at a global level, was critical for development of diagnostics and vaccines, beginning a day or two after the public announcement of the sequence. And this has never happened before, except for influenza, where the system exists. It is not happening in any other, for any other disease, infectious disease. So again, it would be really good to expand this type of activity, to have these databases that researchers from all over the world can upload their sequences to, and there's global collaboration in analyzing this and coming to some conclusions and learning more about the disease. So malaria, tuberculosis, all of these could benefit from this type of expansion. So this is again a lesson that we need to learn and take forward, and certainly having a nationally coordinated mechanism, as has been set up now in India. I think a consortium for genomic analysis has been set up. Countries that have done that in the past, like South Africa and UK, are the ones who've really been able to take advantage of their scientific capacity. What were the other lessons? It was clear that the public health response was a challenge in many countries when suddenly we had to put in place huge amounts of testing, the contact tracing, isolation, quarantining, etc. This needs obviously a workforce. It was believed by some that mobile apps could take the place of people. Many countries thought that they could just develop an app and that would do the trick. And these were many high-income countries. It was clear that technology alone cannot solve the problem, and that you need a system in place, you need a governance, you need human resources. In fact, the developing world, I think, did a much better job of contact tracing and isolation and those kind of public health measures where you actually need people on the ground. And we were able to use our vast network of community health workers, ASHAs, BHNs, etc. But what it did was take these people away from the other jobs that they were doing. So when we did a pulse survey in July, August last year across 100 countries, we found that the majority of countries reported disruptions in essential health services, starting from childhood immunization to non-communicable disease care, including cancer treatment, hypertension, diabetes, tuberculosis, malaria, essential surgeries, blood transfusions. All of that was affected because manpower, equipment, resources were all mobilized for COVID. So a lesson for the future is when there is a shock to the system needs to be able to take action for the new challenge, but also continue the essential health services. And again, this is an area where we don't have data, or at least I'm not aware of data from India and many countries documenting the impact of the disruptions in health services on diseases like cardiovascular diseases, hypertension. I know TB, there was a reduction in case finding for up to 50 to 70% from pre-pandemic, and it still hasn't come back to the baseline. We're still, I believe, 30% short of what cases we would have expected to find in a year. So God, we don't know those cases, whether they have survived, whether many of those MDR TB cases would have progressed or died. Similarly, for HIV, there was a lot of concern and modeling had shown that if you had disruptions in HIV, in TB services, you could have up to 500,000 deaths occurring. The other very concerning thing in terms of TB is that TB incidence is directly correlated with poverty, with undernutrition. And when you have GDP per capita falling, when you have the most vulnerable of the people who are already in a very fragile state, the lowest in the socioeconomic group, they are the ones who suffered the most actually. When you look at income loss and the top quintile and the bottom quintile, the top quintile, there was a survey in Mumbai that showed that their incomes came down by 20%. Of course, many people had an increase in incomes. Those are the super rich. But the bottom quintile had a reduction in salaries, in income of over 50%. And many of them still have not recovered that. So increasing poverty and undernutrition will lead to increasing tuberculosis incidence. That's very clear in the years to come. So again, these are going to be the future impacts, which we have still not seen. And I'm not even going into education and what the lack of children being in school for the last 1 year is going to look like on those children's future. But that's a very serious after effect as well. Then I want to talk a little bit about R&D and innovation, because I was involved really in the center of things. We convened very early in February, scientists, academics, doctors, researchers, public, private companies to look at what are the gaps in knowledge. At that time, of course, there were huge gaps because we didn't know much about this specific virus, what needed to be done, and we laid out a research roadmap, which I must say a lot of funders have followed over the last year. And we also set up these expert advisory groups, which are composed of experts from around the world, to look at things like animal models, standardizing the laboratory assays, developing target product profiles for vaccines and drugs, developing template protocols for things like sero-epidemiological studies, for vaccine clinical trials, etc. And then also coordinating the Solidarity Therapeutics clinical trial, which was looking at repurposed drugs for the treatment of COVID-19. This was done across the world, 30 countries. At most countries bore the expenses on their own, so the WHO did not have to do a lot of funding. It was a huge collaboration with hundreds of principal investigators. In fact, Dr. Reddy is on our executive group of the steering committee. And I think it's a great model for R&D into neglected diseases. I mean, I always think about TB because I've spent a lot of my life working on it. It's so slow. You know, why can't we have these globally coordinated trials to test new drugs, to test new vaccines, to make advances? But again, I think the interest in this case was because this is a pandemic. It affects every country in the world, including the high-income countries. So the amount of R&D funding that's gone in, just looking at Operation Warp Speed alone, and what they've spent on developing vaccines is one of the reasons why we have so many successful vaccines today in the pipeline, and as well as those that have been approved. So I think the way in which the community of innovators and R&D, biotech companies, small companies, large companies responded, including in India, in developing not only vaccines, but also diagnostics. There have been very nice, CRISPR-based paper diagnostic tests that were developed by the CSIR, for example, that's been licensed out now for commercial purposes, as well as in the area of digital tools and technologies, and how telemedicine, telehealth, mobile services, SMS, the apps that were developed both for tracking people, but also now I think for the vaccination campaign, the COVID app, all those are amazing innovations that should be now applied to other diseases as well. There's no reason why we should not use telemedicine in a much bigger way, so that specialists in cities can actually provide good care to people living in remote, rural or tribal areas. Because internet connectivity is now pretty good almost everywhere in the country, and patients should be able to connect even in group appointments, what we call virtual shared appointments. And a colleague and I wrote an editorial about that last week. It was out in the Hindu about how we need to test this approach to provide better quality care for people living in remote areas and to save them time and resources of travel, and at the same time be able to keep up that contact and the counseling that you need. Similarly, I think it can be used for vaccination programs, particularly to deal with the hesitancy, where if individuals can talk to some trusted public health person about their doubts about vaccines, it might be motivate them to just help them to clear their doubts. I think a lot of people have genuine questions about what these vaccines, how soon they were developed, what are these new platforms, what are the side effects, and we need to be able to clear those doubts for them. So they're not anti-vaccine people as such, but just people who have questions. So innovation, R&D, mobile and digital technologies, all of these can be used for the future. And the last point is really about, I think, the building of trust between government, public health agencies and leaders and the community, where you can see in some countries where there was very clear communication with strong leadership, there was a well-coordinated response, communities were engaged, empowered, and this is something, again, Dr. Prasad Rao knows a lot about from the experience from HIV, that ultimately the success of the HIV program in India was because the affected communities were involved. And I think we've learned now from the early days of the pandemic, when it was a top-down response in most countries, that those which had very good community-based primary healthcare systems, community health workers who spoke with the community, engaged them, developed solutions which suit them as well, because solutions cannot work if they're not accepted by people. So I think the experience in Dharavi, the experience in many cities, including Chennai, where the fever clinics were set up, it was made easy for people to come and get tested. Supportive isolation has to be provided, because if people are living on daily wages and you isolate them for 14 days, there's a real worry about what's happening to the family. The social support needs to kick in as well. You need counseling. All of that needs to happen, and it can only happen when many departments and ministries come together. You need really an intersectoral, what we call all of government and all of society response. But it's essentially, unless the systems are in place, unless there's already a decentralized system of public health and primary health care, which is down to the community level and has that engagement capacity, it's difficult to suddenly build that. So again, when we look to the future and we look at our primary healthcare system, we need to look at not just the supply side, but the demand side. How do you engage the community? How do you address their needs and concerns? How do you look at, the determinants of disease as well, the risk factors, and not just the treatment part of diseases? So very often, I think the establishment tends to focus on diagnosing and treating diseases rather than on trying to prevent them. And of course, prevention is not easy. It needs interventions in a lot of other areas. If you want to prevent road traffic injuries, which during the lockdown obviously went down to zero because there were no vehicles on the road. But the moment you get the vehicles back on the road traffic injury is one of the biggest killers in the developing countries. They're increasing actually year by year. How do you address, nutrition, of course, clean water, sanitation, air pollution, etc., indoor and outdoor? All of these contribute to good health or ill health. So these things cannot be done by just the health department or ministry. It needs interventions in many different areas. So this is where, if health becomes a priority, then it needs to be considered, and in every policy that's being developed. So I think that those are probably some of the main lessons. And maybe the last thing I would like to talk about is, as I was talking about trust and communication, is about what we call the infodemic, which was the availability of information through all these social media platforms that we have now. It has its good and its downsides. The good, of course, is that you found that scientists and people were putting data out there in the public domain even before it's peer-reviewed and published. That's the normal scientific process. So when you see something in a journal, it's been peer-reviewed, you accept that it's gone through some quality control. Whereas when you look at the preprint servers, anybody can post anything on preprint, and it may or may never get published. But the preprints often are, of course, accessible to the media, to the general public, and can create a lot of excitement or hype or hope. And very often those are not validated data. So the infodemic is partly the over availability of information, and secondly, the well, there are large groups that are providing misleading information, conspiracy theories, etc., that are being peddled by people, not just about vaccines, but about COVID itself, saying that it doesn't exist, it's all a myth, etc. You have lots of educated people, even doctors, who believe in this. I've seen that there are some Western groups. So people get very confused, and they also get a bit confused because they are used to seeing the end products of science. They are not used to science being discussed every day on a day-to-day basis in the television and newspapers. So an average person might think that these scientists are very confused because they keep changing their minds, and they told us something yesterday and then today they're saying something else. But that's the way that science evolves. It's the knowledge is constantly being generated, and you have to change your views and your interventions based on the accumulating knowledge. So this, unless it's explained to people, can be confusing, and they may think that, well, they don't know what they're talking about because they keep changing their mind. And at the same time, we have to be open and transparent and humble about the fact that as our understanding improves, we will adapt our responses, and it will be based on the evolving information. So I think continuous transparent communication, a willingness to listen and answer questions, listening to people and what the doubts are. We've been engaging with big social media tech companies over the last year, really working with them to see what are the myths and disinformation being circulated, how can we reduce those, how can we provide more credible information to people who are looking for information on the internet. And also we have been trying to do much more direct outreach to people, not just to governments. Normally we work with the ministries of health, that's what WHO does. But in this pandemic, we have made a special effort to really reach out directly to people, again, through all of these social media platforms, so that we try and provide as much credible information as possible. So yesterday, somebody asked me, do you think the trust in WHO has gone up or gone down since the pandemic? And I said, I'm not sure whether a survey like that has ever been done, but I think we should be questioning the trust in science and in public health agencies, not just WHO. And we've seen in many countries, this questioning of science, questioning of public health has led to devastating consequences. Thankfully, not in India, but we have seen this happen in other countries. But again, we need to ensure that we're always, what we do can be backed up by evidence and data, whether it's new drugs and therapies that are going to be advised for people. In the beginning, there was a lot of hope around some drugs, which did not actually, hydroxychloroquine is a good example. There are many, many clinical trials now that have shown that it does not have a role to play, even though there may have been anecdotal evidence in the beginning. So we need to do the studies, the trials, whatever it takes to really understand whether something works or doesn't work. And we should be willing to accept that data. So start with an open mind, study it, have the hypothesis, test the hypothesis, but then accept the results when they come out in an unbiased manner. So with that, I think I would have shared some of my thoughts from my own experiences and learnings from countries around the world, and also what I think we can learn for the future and where we can focus really to. The goal is the Sustainable Development Goals by 2030. We are actually now falling back. We were on some sort of a track, but now all of that has been disrupted. And so there's a grave danger that we lose out on many of those goals unless we really take stock and make a plan as to how we're going to accelerate the progress towards the SDGs. Thank you very much. And I turn it back to the moderators now.
Okay. Thank you very much, Dr. Swaminathan. I'm sorry, I had trouble with the power. We have a major snowstorm, so I'm using my phone, and it's been a great presentation. And I hand over to Dr. Gregory Fent to take it from here. Greg?
Can you hear me now? Okay, good. Thank you, Dr. Somina, for your remarks. I took many, many notes, and I wish we were in person so that I could ask you some of my own questions. Really quite interesting, but I have the agenda here in front of me. And so I would like to ask now to Dr. Reddy, who I've met 2 or 3 years ago in Jaipur. If you would be so kind as to give us some of your comments and some of your insights, given what we've already heard.
Thank you. It's always a pleasure to follow Dr. Samia Swaminathan, and also a comfort because most of the thoughts that I might have had will only echo what she has so eloquently and elegantly stated. But let me elaborate on some of those from my perspective. Firstly, I believe there are some about 10 lessons which I would like to point out as very important from the pandemic learnings that we have had so far. First, to invest in science, trust science, and be guided by science. And this is a message not only for the scientific community, but for the public and the policymakers. There will be disagreements in science periodically, and there would be different viewpoints put by different groups of scientists at various times. But ultimately, even in that contestation, truth will emerge somewhere, and ultimately some consensus will come. Because self-correction is one of the strengths of science. And if we actually listen to what Louis Pasteur said, keep your enthusiasm, but let strict verification be its constant companion. I think that will be a good lead for us. And of course, collaborative science is absolutely important because the multidisciplinary, multi-institutional collaboration is particularly important in speedily advancing science in a pandemic situation. The second is invest in strong health systems at all 3 levels of care, but especially in primary care, which is the foundational basis, whether it is early identification of persons with symptoms, for prompt testing, for contact tracing, for isolation, home care, care of long COVID, or even in terms of detection and treatment of comorbidities like non-communicable diseases. It is ultimately the primary health care which will be the main theater of action. And we also like to recognize that these are not going to be built overnight. Unless you have an efficient and equitable health system functioning in the steady state, you cannot suddenly create a surge response as an ad hoc measure. So you do need to invest in it constantly. And third is you do need a multi-layered, multi-skilled health workforce. And that particularly has to focus on primary care, but other levels of care as well. Fourth is that we do need technologies which are appropriate and affordable, and we do need to invest in that as well. But that alone is not going to sort out your problem, because if testing alone were to be the major element, then the United States, with the largest number of tests, would have done very well so far. It is the other elements of the healthcare system that need to be brought in as well. Testing, tracing, treatment, and appropriate use of technologies is also absolutely critical. And there again, science and public health must go together in making the right judgments. Then we have also the need for public health capacity and public health cadres, particularly in India, where the public health capacity has not been systematically built up. We do find there's been a deficiency at various levels, right from planning to field work, that could have been actually addressed if we had sufficiently invested in public health capacity. And even for contact tracing, as Dr. Swaminathan has very clearly said, we do require more than just apps. Epidemiology and public health involve both shoe leather and smartphones. Then we also require an all of society effort. And there we do definitely require what I would call people-partnered public health. Unless people engage actively, whether it is fear or stigma that was evident in the initial stages or vaccine hesitancy that is seen now, you will not be able to break down a number of barriers which really advance public health action. And therefore, building in the largest number of partnerships, of course, with multiple stakeholders, the private sector comes in, the production of essential equipment, but citizen participation, participation of community-based organizations, all of this is going to be absolutely important. Then it's not only national solidarity, but we require global solidarity, overcoming some of the selfishness that sometimes comes into vaccine nationalism or countries grabbing testing kits and PPEs out of turn. So all of that has to overcome because of the simple lesson that has come up in the pandemic, that no country is safe till every country is safe. And of course, the global collaboration is at its very best when you can actually collaborate in science, as well as in ensuring that there is equity in access to global supplies. Then, of course, we do require regulatory systems which are very strong. Unfortunately, in India, we have had weak and somehow regulatory systems which are somewhat ambivalent, whether it is testing of vaccines or speeding up regulatory review of vaccines. We do require good regulatory systems to come in place. And of course, we do require also to ensure that public health actually also acquires the skill of becoming trusted communicators, public health professionals. Because in this age, as Dr. Swaminathan has said, where social media is active and you get a lot of fake news also floating around, there is much to be countered and much to be also advocated in terms of the right beliefs and right practices. Therefore, it's absolutely important for public health professionals to become very clear and trusted communicators, just like one of the role models that we see, Dr. Fauci. There are so many others too, but we must definitely ensure that we go that way. And for example, the belief that herd immunity has already arrived in India has led to laxity, and people have started behaving as though the epidemic has ended. These are the kind of things that need to be clarified repeatedly if we have to really proceed on the public health pathway. Finally, I would say it doesn't stop with the health system. We know that these pandemics have come in because of ecological despoilation, because of deforestation, building in a conveyor belt for forest-dwelling viruses and vectors to come in repeatedly for microbial transmission from wild animals to veterinary populations to human habitat. And we know that our food and agriculture systems with captive animal breeding are also responsible. So unless we as public health professionals look beyond our nose, look beyond the health system into the wider societal array of the determinants of pandemics and take action there as well as passionate advocates of ecological common sense, we will continue to be fighting pandemic after pandemic. Therefore, let's set our health systems in order, but let us also set our social systems in order. Thank you.
And thank you, Dr. Reddy. I took several notes as well, and I definitely could see the connection between, and I certainly appreciated your list of 10. And connecting the importance of the public health workforce, which is something that you mentioned, and that's also something that our keynote speaker mentioned as well. So thank you. Let's see, and I think now I turn it over to my colleague, Jagdish Harsh, because he's the moderator with me as well. So.
Yes, good evening. Thanks, Greg. Great sentence, Professor Reddy, about the shoe leather and the apps. I guess I should steal this sentence for my mobile application marketing, because I think a lot of startups will do better with some shoe leather, not just the apps, not just for the public health. But without wasting more time, I'll invite a legend in his own right, Mr. Prasada Rao, for his comments. And Prasada Rao, he has been a national health secretary, and he recently also launched his book, Celebrating Small Victories. So I think in the same context, Mr. Rao, if you could please reflect your thoughts on what Samia just mentioned about our battle with COVID, please.
Thank you. Thank you, Dr. Harsh, and thanks for the excellent presentations by Dr. Soumya and Dr. Srinath Reddy, who are world-renowned experts in public health and in prevention and promotional health. I won't be touching any of those issues because they are experts in that, but I will focus more on the policy side a little bit and on the response, focusing more on the India's response. First of all, on the global perspective, COVID certainly is an unprecedented health emergency, but this is not the first one. We had earlier epidemics also. We had HIV/AIDS, we had bird flu, we had swine flu, so many of them. But at no point of time, the world has learned any lessons about investing in health. And then I think once the epidemic is over, I think it was business as usual. In fact, even though AIDS ended with about 40 million people dying, but still it didn't stir the people into action. Mainly because it did not have an economic impact the way COVID has. I think that is the real issue here. But AIDS, of course, had an economic impact, but that's in a very limited area. The sub-Saharan Africa is where the economies have been hit hard and some of the health indicators have come down. But rest of the world, well, I think they just moved forward. They thought it's over. So, but the economic impact of COVID has been devastating. The irony is that the country which had the first impact somehow escaped with the minimum damage, that is China. But most of the other countries, I think they really went back a few years, if not a decade or more, into economic progress. I think that is one thing which probably made people realize, especially the policy planners and the political leaders, that yes, it's time now. I think we must invest in health. So there is therefore an urgent need to invest in health sector, but these are costly lessons which have been learned because it has been several decades of neglect of public health, both promotional as well as curative health, especially primary health in many countries, especially the developing countries, which went on spending a very meagerly 1% of their GDP on health, which is absolutely unacceptable. But then that's how things went on. If you look at the present budget of Government of India, I mean, it showed a very big scale up. But if you look at the individual allocations of the health sector, there hasn't been much of a change. You have to deconstruct the budget as it is presented to see that, yes, I think we are more or less still existing in the same scenario. Especially if you relate it to the primary health care and then the Ayushman Bharat program, etc. in India. I think not much has changed. So I think the lessons are yet to be learned. That's my feeling. And if we continue forgetting those lessons, and again, once 2022, come 2022, there's no COVID, and again, it is business as usual. That is the biggest apprehension I have. But I hope at least the lessons will be learned in India, if not in any other countries. Now, looking at India's response, I think earlier also we discussed it many times. I think it is not a black and white type of an issue. We had great successes. I think containing the epidemic to manageable numbers, I think is a great feat that India has done. And also mortality, low mortality. We got away with low mortality, even though in terms of absolute numbers, it's very high. But I think we have been able to contain the epidemic to a very low mortality rate. And also the recovery rates are so high, which are some of the very, very important features of India's COVID response. And most importantly, within a very quick 1 or 2 months, we have been able to become self-reliant in a number of preventive tools and technologies. I think that is really remarkable. When the epidemic started, we were not even in a position to even buy very normal things like masks in this country. But from there, we now are exporting probably masks to several other developing countries. Same thing with ventilators, same thing with other equipment. So it has been a great journey in the last 1 year to develop indigenous capacity in health technologies, especially in the on the prevention side. I think which is again a very, very positive aspect of India's response. And of course, the vaccines. I mean, India is one of the few countries which has produced not 1 but 2 vaccines, and both have been introduced. We have not yet gone for any outside vaccine, and we have a massive vaccination program already existing now, and it's going to get scaled up from 1st of March to include all the elderly people and also people with comorbidities. So these are some of the very positive things, I think, for which both the government and the the scientific community and people at large need to be given credit. But having said that, there have been a number of failures. I think we must definitely take notice of that. First of all, if you look at the primary healthcare level in India, which is the first point of contact for any healthcare, very little happened in COVID at the primary health level. People had to run to secondary or tertiary healthcare units for COVID treatment. Nothing was existing at the primary healthcare level. There is a complete collapse of the primary healthcare system during the last 12 months of COVID response. I think which is a very costly mistake. We now need to invest a lot on the primary healthcare, at least on these wellness centers and others that government is trying to establish. Then the second is non-availability of drugs. I think initial stage at least, the drugs were very much in short supply, especially at the cutting edge level, they were not available. And there has been a lot of profiteering that happened in the initial stages. But later on, of course, they came out. And then we have almost given a free ride to private sector to profit. I mean, this is unpardonable because we hear horror stories of how people have been exploited in small little nursing homes when they went for treatment, etc., without any regulation, without any supervision. I mean, you can't just throw the people to the mercy of profiteers. I think something has gone wrong in the system by which I think people have been taken for a ride on this. The other is the migrant crisis. I think this is, to me, is one of the biggest mistakes that happened. We somehow got into this migrant crisis without notice, without probably any anticipation. And for the next couple of months, the entire energy of the government was spent more on tackling the migrant crisis than COVID-19, which is completely avoidable. I think it was completely avoidable. I think that has diverted the energies of the government. Maybe there are lessons to be learned from this. Maybe in any future emergency, we need to look at migration as a very, very important issue in India, which often we don't take notice of. Then the entire response, some or the other, initially at least, it gave the feeling of a top-down approach. Because everything, including many of the state governments, were just looking to Delhi for orders, for guidance. And public health is essentially a state subject in India, and a lot need to be done by the state governments, and they should have the freedom to innovate, to improvise, to do new things. But somehow or the other, everything is a straitjacket. And I think just they were obeying orders and following whatever instructions have come from the government of India. I think that never happened before. At least in the case of HIV/AIDS, I can speak for myself. Initially, when we produced the data and gave the response to the states and decentralized it, the states innovated. They developed their own interventions. They developed their own prevention technologies, preventive tools, etc., and went ahead. And the government of India just gave them encouragement, gave them the technical support to do that. I think that should have been done here also. Somehow I have a feeling. Then the other issue is, as Dr. Reddy has said, people's participation. Again, something which was strikingly absent, especially the community participation. This is a big success story in HIV/AIDS and also in the eradication of polio in our country. The way communities came very strongly and got involved in the response, that was the secret. Somehow or the other here, we have not seen, even now, the involvement of the communities and the recognition of the importance of communities in a response like this. That doesn't mean communities have not done anything. They have done a tremendous work, which has gone unacknowledged. In the field, you can document, you can chronicle a number of success stories where community-led action has really led to great successes. And we also have this great example of COVID warriors forming their own networks in places like Kolkata, etc., and looking after niche areas like counseling, which has not been included. Counseling is not something we find in COVID response at all. Whereas counseling has always to be a very important component of any public health response to an epidemic. It is not there this time. But many of these COVID warriors have done exactly that and went to households and tried to counsel people. So some of these missing elements, I think, are there in COVID response. So we must acknowledge it. But I think the lessons that we learned, I think I will just take 2 minutes and stop there. I think we need to invest more in primary health care. The health policy 2017 says 70% of the health budgets must go to primary health care. It is not yet happening. It is just there on paper. We need to see that it happens. Second is there should be space for civil society to be partners. There is no alternative to this. I think that lesson needs to be learned. Third is regulation of private sector. You need to have a regulation how private sector can operate. I mean, you can't just give them a free ride. They're important. They're very important constituents, very important partners, but it can't be just let loose to make money from people, especially from the poor people. And finally, there should be greater emphasis on preventive and promotional health and the social determinants of health. One good thing with this budget is they have shown the investments that government is going to make in the social determinants to health as a part of the health program, which is good. But I think the kitty has to be much larger than that. So these are some of the, initiatives that government has to take, taking advantage of the lessons that we have learned from the COVID response. I stop there. Thank you.
Thanks, Mr. Rao. We all continue to learn from you. What a legend you are. And, these all points are so important. And I think a lot of our users who are on YouTube and Facebook all taking note of your critical points, especially about the primary health care and the points that you have mentioned about, the COVID response that we have had. I'm sure that someday you will be able to write a book about common mistakes. How can we rectify for the COVID response? Like
that is for Dr. Samia to do, not me.
But celebrating small victories was a good book. Now we need a book about how we can correct small problems, small mistakes, so that we can have a better public response. Public health response. Anyway, thank you, Mr. Rao. I invite now another legend in his own right, Dr. Mathur. He comes with an experience of 44 years and a former principal of Dr. SN Medical College, Jodhpur. Kindly, Dr. Mathur, please reflect your thoughts about what our COVID response had been. Thank you.
Thank you very much. It has been indeed a privilege to learn from our distinguished speakers, Dr. Samia Swaminathan, Professor Srinath Reddy, Dr. Prasada Rao. And I think the lessons which I have learned, Dr. Samia has given an overview of this. This is the time when public health is being talked about by the common person also. Earlier, the meaning was not understood well by even the medical professionals. And at this particular point, I'll just like to share first that there is a need for implementation of what we have learned. And there are certain sincere efforts which have been shown by government of Rajasthan recently. In their budget, they have proposed that they want to have a model of public health of Rajasthan being established, with establishment of public health colleges almost in each division, and also to spend a lot of money. And it's probably the first state which has committed to the universal health coverage for the whole state. Now, at this particular point, it shows their willingness to do it. But I'll request Dr. Samia to tell us how could they be guided for developing an appropriate plan for execution of these wishes, basically. Can you suggest us something from them first? Because the government has shown their willingness to spend money for this and to establish a public health system in Rajasthan state.
Yes, Dr. Mathur, I think it's really very encouraging, and maybe that's the state that, there are some other states that have done so. Tamil Nadu is one of the states which has established a public health cadre long back, and you can see the benefits of having a separate public health cadre and a public health infrastructure in place, not just for infectious diseases, but also for management of, other things, NCDs, etc. I think the vision was laid out quite well in the national health policy. I think Mr. Prasad Rao also just mentioned that how much of the budget should go for health, how much of that should go to primary health care, what are the cadres that need to be created in terms of human resources. I think we have a lot of work that's being done, a lot of documents. So we don't need to reinvent the wheel. I think it's a question of implementing it. And we have enough stalwarts and experts in India who will be able to guide, but it's a very good thing that this has happened now.
I think there are these documents are there, but I think a word from your end or from all the distinguished experts would make difference to the state. So I will like to connect for that particular thing.
Sure.
Yeah.
Happy to do that. Yeah.
Yeah, it will be our privilege. Secondly, one more thing which we noticed, because I'm a practicing physician and I've been looking after the older people. So the COVID has shown a major impact on the older adults because of in the West, they had a major problem with their long-term care facilities where they had a lot of infection and mortality. Luckily, we do not have such facilities to that extent in India. And our older people are most of the time staying in community itself. So that's why we didn't face that problem. But the older people during this COVID time had other issues. Of course, with the severity of the illness due to their vulnerability and other comorbidities, they had other problems of access to the healthcare for their existing diseases. Secondly, the lockdown and the social isolation also caused a lot of mental health issues. One more thing which we observed in the older people was that they couldn't understand or abide by the public health measures which were being talked about. They suddenly felt that lockdown wise should be there, even the use of masks, etc. So that understanding is also different in the older people. Then one more issue which came up during the lockdown was missing. The caregivers were missing, and the individuals who were dependent on their caregivers, they had real hard time during the COVID. And we realized that the inception of telemedicine has been of great help to them, because once it started, at least teleconsultation helped them, and the use of other assistive technologies are useful for them. So I think in future, we need to work upon a community-based healthcare system for the older people, where we could use these technologies along with the home care systems for the older people. COVID has shown us so many lessons, and I think post-COVID, the medical practice is going to be different altogether with the induction of telemedicine and other ways of distant virtual care. We will be changing the medical practice, and that is going to be more for the geriatric care or for the care of the older people. There is a need to have infection control practices instituted in all the settings of the care for the older people, may it be an old age home or may it be a community or at the home environment itself. So I think COVID has shown a major problem for the older people and their care. We need to learn, modify the way we will be taking care of the older people over here. And I think now during vaccination also, it's a good part that this age group has been considered and is going to receive the vaccinations also. And I like to say that in our part of the state, things are going so well with the regarding the vaccination, and even about the healthcare system also wise. It was the care which was available in our place at AIMS Jodhpur, or may it be SN Medical College hospitals, etc. That was useful for the older people also. I think that's all from me at present, while pass it on to Dr. Jagdish. Please. Yeah.
So I will take over now. Thank you, Dr. Mathur. Dr. Harsh has some internet problems, so he just texted us. So I'll take over from here. Thank you. I have listened to all of you so far, and I can't wait to hear the comments of our last two speakers. And I have so many notes, and I will come back to someone and ask something, right? But I think on my agenda here, I have Dr. Pankaj next. And so I would like to ask you, sir, if you could reflect with us on what we heard at the beginning and perhaps share with us some additional insights that you have from your professional practice. So thank you.
Yeah, thank you so much. I think it's a wonderful opportunity to speak after these stalwarts who are already deliberated upon most of the points, and it's a bit difficult for me to add some more insight to the entire issues. But let me take you to my scenario, because I represent an academic institution. So I belong to All India Institute of Medical Sciences, and that too in a small town of Rajasthan. So I'll not call Jodhpur a big city, but that's a big city in terms of demography or geography, but it's a small town. So what we have learned during these COVID-19 pandemic is for a medical school or for academia is number one, though we are academic institutions, but at the time when these kind of pandemic situation arises, the challenge was again the same, to maintain that essential health services during COVID-19. And at the same time to provide that quality treatment to the people who are coming to our hospital with a trust. So believe me, it was a tough situation for us, because in a situation like COVID-19, the treatment protocols were not available. Rather, the guidelines were keeping on changing so fast. And as Dr. Swaminathan and Dr. Reddy has already spoken about, that it was a kind of a situation where there was a kind of distrust on the science even. So, but the best part we learned was that when we were dealing with the entire situation, we participated, or the institution like AIMS, they start participating in multi-centric, multi-country studies and start generating evidences. So though the treatment protocol, they changed, but they really helped us out in getting a kind of, treatment modalities to the people who are actually coming to our hospital. Now, the second thing which I felt, which we felt as a hospital was that usually it happens that when there is a surge, the already crowded hospital or a tertiary level care hospital is expected to deliver services. This is the time when we found that opportunity to get connected to peripheral, centers or to PHCs and CHCs. So the lesson learned was that yes, it's highly doable. It's a kind of hand holding between the state health departments and the academic institution like AIMS, where we sit together, we develop SOPs, and happy to share with you is that we try to develop those protocols, when to refer, when not to refer these patients, because we are already overburdened with the kind of surge which has been there, and we have lot of hospitals who are being underutilized, and they're in the peripheral hospital. Just to share like small things like use of high flow nasal oxygen that can be delivered to a primary healthcare center and a CHC. But those doctors need to be trained. We are medical teachers. So it's the time when we start working on these principles through telemedicine, through the capacity building of our own people. So we start learning, we start enjoying rather. I'll say these words because our old students, though they are not from the critical care, so every patient doesn't need that critical care, facility. Small things they need to be trained at, and these state health departments, they approached us, and we did try to provide that kind of capacity building of these people. What we felt a challenge for us was when we came to know that even the medical schools were not equipped with diagnostic facilities of having a quality RT-PCR services. So these kind of situations or this pandemic showed us what actual reality was. Many of us remember that these kind of diagnostic facilities are a must in a medical school. So, but this situation provided us an opportunity to mentor the medical schools, and not only medical schools, the district hospitals. District hospitals, they can be having this facility of having the RT-PCR facility, or quality these technicians who can provide us the reports. So what we felt was that because I'm representing the academic institution, that it's the time to come out of the domain of just in the medical school. So it's a kind of a hand holding between the state health, the kind of academic institutions, and everybody has to come out of their space and to join hands. as our astronomers have already, deliberated on that, we have already faced this situation, and these weaknesses, now we can take them as an opportunity to strengthen our health system. So I think that was a kind of learning for us, that we need to come together, and then academia and the health facilities which are already existing in the public sector, they need to work to face this situation. Thank you so much.
And thank you, Dr. P, for sharing those thoughts with us. I think you were there in Jodhpur, if I'm not mistaken.
Yeah, Jodhpur. Yeah.
I am hoping to see you the next time I am there.
Oh, that's true.
I have some I have some questions for you as well. So thank you.
Sure, privilege. Yeah.
Thank you. Finally, Dr. Godrich, you have had the and it's nice to see you again. You've also had the opportunity to listen to our keynote speaker as well, and all of our other distinguished speakers here as well. And I just wonder if you could also offer for us some of your insights and perhaps one or two things that particularly spoke to you and that suggests some other actions for public health.
Absolutely. Thank you so much. It was really exciting to hear from all these incredible speakers who gave us a wonderful understanding of the challenges that we're facing now in India. And I can just tell you from a local situation here in Mumbai, which Anil wanted me to comment on, is that yes, we are seeing a rise again of number of cases from what was about 500 cases per day to 1,000 now. And certainly, fortunately for us, they're not very serious cases requiring ICU care. And the mortality rate has not gone up significantly. So those are all extremely reassuring for us. However, the question is, why are the number of cases going up? And I think my insights are, one is that I think everyone is patting themselves on the back saying that, India is so much better off than many other countries. And I think that is leading to some amount of complacency in following some of the guidelines. So I think that's number one. Secondly, I think there is tremendous COVID fatigue at this stage. And Mumbai, being a very bustling metropolis with economic activity, people are extremely keen to get back to work and to get their employees back to work. And how are they doing that? They're doing it by opening public transportation. So ever since the lines, the train lines and the subways have opened in February, there's been 4 times as many people traveling on trains. And again, that is a recipe for people coming together, and certainly infection spreading from one part of the city to the other. So there is a lot of discussion going on right now with the chief minister and with the state government here about whether they are going to limit the number of people who are going to be using the public transportation and the trains, particularly to get to work. And I think lastly, I have to say that I have seen that there is tremendous COVID fatigue and people wanting to socialize, thinking that it's now okay to socialize. So we're seeing an increased number of people going to restaurants and certainly attending large venues, weddings especially. And I believe that many cases have been found where these groups of people have congregated for weddings or particular religious ceremonies. So I think that's something that needs to be looked at. Now, how do we solve that? I really think we're dealing with behavior challenges here. And I think coming from a government point of view or top down may not necessarily be the answer. We really need to work with the people in the communities to see how we are going to solve some of these issues about them socializing, how to give them adequate policies for what they can and cannot do. Because I think it's very difficult for them to be in their homes in a lockdown situation after 11 months of a very strict time of lockdown for them. And I think we need to increase our communication with the communities to tell them how to effectively communicate with the local community leaders and with the media in the various languages about how they should be managing the pandemic at this stage and how to look at the behavior of many people. Because as we go around the city, we do see that the number of people complying to wearing masks or using sanitizers is quickly decreasing. And that's unfortunate because we're going to be hitting various surges. And I think people are thinking that the pandemic for India is certainly over the worst. And I hope it is, very much so. But you never know, as we've seen from many countries, where we have to still be very, very prepared. Hope for the best, but definitely be prepared for the worst. So thank you.
Thank you. Thank you, Dr. Godrej. I was shaking my head because a lot of what you were saying, I thought of my own family here in the United States. And I know that one of my family members is certainly more active than I am and wants to get out there and be with friends and do all the things that used to happen before the pandemic. And we're not there yet. So what's the best way to re-engage in a slow and responsible manner? That's the question. And, and I don't think any of us know yet. So that's the question. Yeah, yeah. Thank you.
Absolutely.
So we have heard from so many people, and if you don't mind, as the moderator, I'd like to ask one question of Dr. Samia, and that is one of the comments that you made was the importance of sharing data, and so that's a topic that is very interesting to me. When you mentioned the importance of sharing data and working collaboratively in a global way, I couldn't help but hear open data, you know, and the need for open data, but also that there might be a role as well for data science methods to really help us understand what's in data sets and to bring various data sets together to find insight. Is that what you meant?
Yes, I mean that data is obviously a huge area. It's also very complicated because you have different types of data with different elements of confidentiality and privacy attached to those. And you also have data that's generated by research institutes and academics. You have data that's in the public health domain that belongs to governments. You then have personal clinical data that actually belongs to the individuals, which is now more and more becoming available as electronic health records. So if you really span across, and then you have genomic sequence data and things like that. So what we would like to see is moving towards moving in a direction where we are able to share for certain purposes, and mainly it's for collaboration to advance the knowledge. It's also for things like artificial intelligence. If you really want to apply that to make sense, then you need good data sets which are good quality, but you also need it in large volumes and being very broadly representative. Otherwise, AI is not going to give you the right answers. And so this has happened in pockets, and I think GISAID is a good example of a database which has certain terms and conditions associated with signing up to it to use the data, which in a way protects the people who are putting the data in. So it avoids the kind of situation where the data is generated by a group of people somewhere, but then somebody somewhere else is able to write the papers and get it published without giving due credit. And so it's that issue of trust very often that prevents people from wanting to share their data because they feel they're going to lose all control over it. Right. So that's where we need to define, I think, the operating principles or the rules that will govern it. and then test it out in a few areas. And so from the WHO, we would really like to see, drive this forward, but it could also start in India, in countries themselves, having national systems, because even that doesn't exist in many countries, to share data and to develop these interdisciplinary groups that then work on the data analytics and the data science part of it.
Okay, thank you. Thank you. I didn't realize, but you're also suggesting then developing countries, but also, Western countries too, to really have better data governance structures in place so that data can be collected and shared as in an appropriate manner. So that's what I heard you say.
In fact, some high-income countries have the opposite problem. They have a lot of electronic data, but then they have interoperability issues. Yep. I saw in Germany that even hospitals that are next to each other physically are not able to share their data. Then they have the laws that have been developed, which make it extremely difficult for anyone to share any data. And in the case of emergencies, it really becomes problematic. So I think when we develop the data governance and the laws that are going to govern data, and I think in India this is being discussed now, we will need to take into consideration how do you protect people and their privacy and so on, but at the same time use the data, which can really be very valuable for public health action.
Public health action, yes.
Yeah.
I certainly agree. Thank you for responding. So with that, I am done with my portion. So I will turn it back over to Dr. Anil Purohit. Thank you.
Okay. Thank you, Greg. I think this was a wonderful session, actually. And I'm sorry I have some power issues and I'm on the phone now. But I think this is not the end. This is the beginning. I think this was a great discussion. We should take it forward. And to answer Dr. Mathur, your question regarding what you had asked Samia regarding the schools of public health in Jodhpur, I think 3 or 4 months ago on this webinar, we had announced the think tank in global public health and requesting Mr. Prasada Rao to be the chairperson. And we are working on that. I'm thinking that kind of a committee at the state level would definitely help take it forward to the Chief Minister or the Health Ministry of Rajasthan. And then I'm sure we have support from everybody here, Professor Reddy, Dr. Swaminathan. And that's something we should definitely take it forward. And we were probably the first ones to start School of Public Health, though they started in Pilani through the Uniformed Sciences of Health Science in Maryland, but that did not last for more than 2 years. So I think we should have a discussion and maybe set up a meeting and take it forward, I would say. And that's a great initiative, definitely. Any other comments? I think given the time and in the interest of time, we should definitely end this. And reporters have worked very hard, but they will send us a summary report. And we will be sending draft reports to everybody. And I'm sure there are some students and some people on this panel who are very enthusiastic to publish papers. So we would be hearing from them. And so any question, any 1 or 2 questions for any of these distinguished speakers and panelists before we end?
Yes, sir.
All right,
There are
so
questions in
yes.
Q&A.
All right.
So let me ask.
Can you?
The question is from Varun Arora, and any panelist or any speaker can answer it.
And who's Varun? Is he a student or is he odd?
I think this question is to Dr. Swaminathan, actually. Tuberculosis active case finding has reduced substantially during and post-lockdown. One hypothesis is preventive measures like masks, social distancing, etc. may have impact on reducing transmission of TB also. Your opinion, please, ma'am.
Yeah, that's an interesting question because certainly I think what we've seen in influenza this year is that influenza disease has practically disappeared because of the public health measures. But I don't think for TB the effect could have come so quickly. So you can't just have lockdown and then have TB disappearing. So it's, I think, more related to the functioning of the program than due to the actual epidemiology of the disease. But this, we need to track it.
Thank you. And next question, why we are losing important time in initiation of vaccination to general public, particularly at risk groups?
I think we are not losing time because
Right.
the government's first priority should be to vaccinate the healthcare workers and then the frontline workers, because they are the ones who have the maximum contact with the population. So that was the right decision. But without waiting for that to be completed, government has already decided to open it up to the general population. So from 1st of March, senior citizens above 60 years and also those with comorbidities above 45 are going to be vaccinated. So I think it's the right time to get into that mode of expansion of the vaccination program, and I think government is proceeding in the right direction on that. Thank you.
That's it. These were two shortlisted questions.
Sure, great. All right. So thank you, everybody. I think this was a great session. And thank you, Soumya. I know your time is always so difficult to get out from your work and daily schedule. And we are really happy that you could make it. And also Dr. Reddy, Mr. Rao, Riti, Pankaj, and Dr. Mathur. This has been a fantastic panel. And we all will be in touch with you and we'll be sending you the report. So thanks. And Bhupesh, do you want to take a picture? Ritual?
Yes, sir. Please. Maybe have a group picture to make it memorable and keep the memories.
All right.
I request all panelists and guests to turn on the cameras. So we'll have a picture. So say cheese, 3, 2, 1. Bye-bye. Thank you, everyone. Bye-bye.
Bye. Thank you.
Thank you.
Thank you. Bye-bye.
Thank you, ma'am. Thank you.